Honorable Professor of Obstetrics and Gynecology Department, the Honorable Study Program Coordinator of Obstetrics and Gynecology Department, Dr. Ernawati, MD, PhD. The Honorable Professor Jose Miguel Palacios-Jaraquemada, MD, PhD, as the Adjunct Professor of Obstetrics and Gynecology Department, Faculty of Medicine, Universitas Airlangga, Dr. Sutomo General Hospital, Surabaya. The Honorable Senior Staff Members of Obstetrics and Gynecology Department, the Honorable Senior Staff Members of Faculty of Medicine, Universitas Airlangga, and Dr. Sutomo General Academic Hospital, dearest residents, and also to our distinguished guests. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Alhamdulillahirabbil alamin. Let us praise Allah Subhanahu wa Ta'ala. Because of His blessings, we can be healthy in a good condition and participate in this event. Salawat and salam may always deliver to our beloved Prophet Muhammad Sallallahu Alaihi Wasallam. This morning, 24 November 2021, we are in the Adjunct Professor Inauguration Ceremony organized by Obstetrics and Gynecology Department, Faculty of Medicine, Universitas Airlangga. In this precious opportunity, the Obstetrics and Gynecology Department, Faculty of Medicine, Universitas Airlangga has proudly invited Professor Jose Miguel Palacios-Jaraquemada from the Department of Anatomy, CHEMIC, University Hospital, Buenos Aires, Argentina. Before we start our inauguration ceremony, may I bring the rundown today. First opening, continued by national anthem, Indonesia Raya, and Hymna Airlangga. Curriculum vitae reading, opening speech by the head of Obstetrics and Gynecology Department. Welcome speech by the Dean of Faculty of Medicine, Universitas Airlangga. Scientific oration by Professor Jose Miguel Palacios-Jaraquemada, MD, PhD. Speech by Director of Universitas Airlangga. Inauguration ceremony. Expert lecture. And last closing. Thank you for your attention. Ladies and gentlemen, shall we start our inauguration ceremony now? As our love and proudness to our homeland Indonesia and alma mater, Universitas Airlangga, we will listen to the national anthem, Indonesia Raya, and Hymna Airlangga. To all distinguished guests, please stand up.
Jadi palu hidup
be seated. The next agenda is Curriculum Vitae reading by the Chief of International Unit Faculty of Medicine, Universitas Airlangga. Dear Dr. Asra Al-Fauzi, MD, PhD, the time is yours.
Among the many research and academic products he has produced, he has also received grants for 2 of his research. One of them was even funded up to 30,000 US dollar. So that is the fantastic one. Again, indeed, due to the limited time, it is impossible for us to discuss all of the achievement that have been obtained by Professor Jose all this time. But at least with these few slides, we have gotten to know him. We also know how much dedication he has for the work of medicine, especially obstetric and gynecology, which has been able to bring us to this point. I think that's all from me. Thank you for your attention. We hope we can visit Buenos Aires soon, next year after this pandemic is over. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Dr. Asra Al-Fauzi, MD, PhD. Ladies and gentlemen, the next agenda is the opening speech by the head of Obstetrics and Gynecology Department, Faculty of Medicine, Universitas Airlangga, Dr. Sutomo General Academic Hospital. Dear Dr. Brahmana Askandar, MD, PhD, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, I would like to express my sincere gratitude to our rector, the rector of University of Airlangga, and also vice rector of University of Airlangga, and the dean of medical faculty, Airlangga University, the vice dean of Airlangga Medical Faculty, Airlangga University, and to all distinguished professors and colleagues this morning. Today is a great day. Today is a milestone day. And today is unforgettable day in the history of our department. We are extremely honored and we are extremely proud to have Prof. Jose Palacios, becoming our adjunct professor. The story of our collaboration relationship between our department and Prof. Jose started in 2016 when Dr. Rossi met Professor Jose in Kuala Lumpur, Malaysia, and continued with 2 visits of Professor Jose in Surabaya. And perhaps in the future time, we would like also to visit the center of Professor Jose there in Buenos Aires. This collaboration, this relationship started in 2016, is trigger us to become a leading center of placenta accreta spectrum disorder management in Indonesia. And our department becoming as one of the leading centers in terms of educating people regarding the management of placenta accreta spectrum disorder management, and also with Dr. Rossi and all the team of Division of Maternal Fetal Medicine, also done a collaborative study that already published in several reputable international journals. We hope in the future time, our relationship will be strengthened, will be closer, and we hope that our relationship is not just in the terms of between maternal fetal medicine and Prof. Jose, and perhaps also between our center and the University of Buenos Aires. As we know that our department have 5 divisions: gynecology, oncology, maternal and fetal medicine, fertility, endocrinology, urogynecology, and social obstetric. We hope that in the future time, we have a more collaborative study and also exchange doctors in the future time. And also we hope that Professor Jose still with us in all education manner, educating medical students, educating fellows, educating residents, and also we can share all our achievement and Prof. Jose's center's achievement, we can share all together. So it will trigger us to come forward together in the future time. Thanks a lot for the Dean of Medical Faculty in our university that accommodating all the process so that Professor Jose can become our adjunct professor. That's very valuable thing of us and will trigger all the development in our department. Once again, to our distinguished professor, distinguished guests, thank you very much. Hopefully that this inauguration will become just a trigger for the next bigger scale collaboration. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Brahmana Askandar. The next agenda is the welcome speech by the Dean of Faculty of Medicine, Universitas Airlangga. Dear Professor Budi Santoso, MD, PhD, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Please welcome to the inauguration Adjunct Professor, Professor Jose Miguel Palacios-Jaraquemada, Medical Doctor, PhD, from Hospital Universitario Resmi, Argentina, in collaboration with Faculty of Medicine, Universitas Airlanga. First of all, I would like to express my sincere gratitude and a hearty welcome to Vice Rector of Universitas Airlanga, Dr. Miftahul Surur, the Vice Dean, Faculty of Medicine, Universitas Airlanga, the Head Department of Obstetric Gynecology, Faculty of Medicine, Universitas Airlanga, the respective professor, senior, and colleagues of the Faculty of Medicine, Universitas Airlanga, particularly from Department of Obstetric Gynecology. And our special guest today, Professor Jose from Hospital Universitario Resmi, Argentina. Distinguished guests and honorable participant, on behalf of Faculty of Medicine, Universitas Airlanga, please allow me to take this occasion to thank all of you for taking time out of your busy schedule to join us today. My most important duty on this special day is to offer a warm welcome to our honored guests and colleagues in the ceremony to celebrate Professor Jose exemplary accomplishment of a long and distinguished career as leading scientist, educator, also an inventor. Professor Jose has earned a bidding respect from his colleagues, devotion from his disciples, and wide international acclaim for his excellent work, especially in placenta accreta spectrum. The achievement of Professor Jose, who has discovered a method of uterine conservative surgery on placenta accreta, certainly has a lot of us to take as example. His valuable experience will deliver it and share to all us through this morning scientific oration and also expert lecture session. We certainly hope that after Professor Jose inauguration as one of our honorary professor, he can transmit his success story and experience in placenta accreta spectrum and international peace research and educational program will position us as a center of excellence in patient treatment, creating advanced knowledge while also facing the global challenge. Again, on behalf of university, it is my great honor to say that we are really honored to have Professor Jose as our honorary professor for his lifetime caring and contribution in the field of the obstetric and gynecology, especially in placenta accreta spectrum. I also would like to express my sincere thankful to Professor Jose. It is currently honorary professor of Universitas Airlangga. Thank you for Professor Jose and all participants involved for your support. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Budi Santoso, MD, PhD. Ladies and gentlemen, the next agenda is the scientific oration by Professor Jose Miguel Palacios-Jaraquemada entitled Our Compromise to Improve Maternal Health. Dear Professor Jose Miguel Palacios-Jaraquemada, MD, PhD, you may begin your oration.
Okay. I really appreciate all your words. I'm being honored by the Charter of Professor. We stayed many times during many years. The collaboration with all the people in Indonesia was very kind, especially with Professor and also with Rosie. Rosie is very open to introduce new ideas. That is very good, and is a good person. Yes, at first, but also is a person that have a lot of compromise. Yes, to change the activity. All the people, or the dean, also the dean, the professor, yes, bring me a space to speak, to share my experience, and we share also a main common problem, because in our country we have a high rate of cesarean and also the quantity of placenta accreta. All these years of investigation were hard for some time, but I also have a support for many people. This is not only my work. Obviously, I receive help for the people in my country, but especially in Europe, that are very stimulated, yes, for the change. You know that the placenta accreta is a very global problem, and next we talk more about this. Now, I try to talk some ideas about our compromise to improve maternal health. You know that many years ago, the World Health Organization tried to reduce in 2/3 the maternal mortality in the world. And this is a big problem, this is a big issue, and reveals the compromise of all the people to modify this. Obviously, the solution is not easy at all, because the factors that affect the maternal mortality are multiple. But we try to, for example, attack the hunger, malnutrition, yes, at first. And this is a problem in many countries. You know, we are similar, for example, in some areas of South America, because we have areas that are more rich and areas that are poor. yes, with not good access to the health, the nutrition, And when we realize about the problem of the complication, the maternal mortality in the world is terrible. If you pay attention to the number, it's about 600,000 people a year. And the causes of maternal mortality are very wide, but you know that especially the main cause in developing countries is the postpartum hemorrhage. You have more infection, obstructed labor, hypertensive, yes, and obviously unsafe abortion. Unsafe abortion was a big problem also in the country, and in special poor areas of South America. And the access to the safe abortion is quite limited. For example, at this time, Mexico City and Uruguay. Uruguay is a small country near to Buenos Aires that fight continuously for the option of the doctor to the government accept the legal abortion. That the woman that want to practice an abortion practice in the safe condition, because the consequences are very complicated, finally in some cases in death. And the same situation happened 2 years ago in Argentina. As is happening in many countries, you have people in favor and people in against. And after a lot of consideration, yes, the government decided to accept the legal abortion. And you know that a part of this, the legal abortion, the introduction of the misoprostol was a very big change, yes, but by the other side, you know that the cost of misoprostol is very high. For this reason, is not available for the people. Yes, and Indonesia is similar, as I said, to a similar part of my country, and especially in, for example, in some areas of South America or Central America. And one of the main problems is the access to the health. Yes, but I found, for example, a very clear video I want to share with you, because the people think that to make some changes is only necessary a big quantity of money, but it's not real. And this is a big example of this, in which the people in Papua, yes, only put attention to the 4 points.
Belum banyak pengalaman lah istilahnya. Sama juga mereka, dampaknya ya mereka juga mengetahui setiap jalannya gitu, mengetahui perkembangan dunia bagaimana, itu dampaknya bagi ibu-ibu yang mau tempat saling tukar pikiran lah gitu. Kita menunggu dipanggil untuk diperiksa.
is an excellent example to you can change some problems with a simple point. Yes, in my country, some people try to introduce this idea to move, for example, the controls to the people. Yes, and change a particular things, not all the scenario, because all the scenario is very complicated. But when you analyze, for example, one special surgery in relation with one simple point, that is postpartum hemorrhage, appears obviously the name of the cesarean. And you know that the cost of the vaginal birth is obviously less than the cesarean. And even, for example, in your country, especially obviously in private hospital, the cost is very high. Yes, and this is a multiple factor to this happen. Yes, and many people around the world try to reduce the rate of the cesarean, but the situation in every country are different. For example, in my country, there is a lot of pressure for the people to perform a cesarean, but also the problems with the lawsuit. If you have any problem, for example, in the vaginal delivery, the people ask you, why do you perform cesarean? Yes, and there is another problem that especially the most quantity of doctors, yes, working in a public hospital, but then at the midday change to the private practice. And for this reason, yes, the rate of cesarean is very high also here. But also the people ask for cesarean. Yes, there is a lot of factor. For this reason, a lot of effort in the world fails, because the situation is not the same in all countries. Yes, it's very good to know, for example, the classification of the Robson cesarean. Yes, I talked with Professor Robson many times, but even him told me that it's quite difficult to introduce this concept. And maybe the people say, okay, but you know what is the problem? Why is so difficult the solution? Because there is in the middle a lot of personal problems, yes, social problems, that the people that ask cesarean, and for other part, the doctor that use more cesarean that is necessary probably. But the cesarean section, yes, is rising in every part of the world. You know, at the beginning of the 1950, there is small quantity of the cesarean, for example, in the United States, about 10%. But the cesarean is rising every year, yes, or every 5 years. But now it is important, especially for the societies, that the people know the consequence of the cesarean. Yes, that is not free of risk. And especially, for example, the relation of the cesarean and the PAS, because the PAS is one of the main cause of postpartum morbidity and also mortality. And many people, yes, dismiss this problem. Yes, I need to perform the cesarean now, and tomorrow is another day. But it is very important that we try to introduce this idea. But the people, yes, don't think in the next day, yet thinking today. And obviously, if you talk, you know the experience, for example, with the tobacco. If you put, for example, a signal in the box, yes, the people read about the cancer, but continues smoking. Yes, it's very complicated to know only with the advice. And Yes, a few years ago, I think the possible solution, because in Argentina we have a high population of the Jewish Orthodox person. For these people, it's so important to have more children. But what is the problem when you perform a cesarean in the first delivery? It's a big mess. Why? Because for religion, they need to want too many babies. But you know, there is a limitation, yes, for the problems in the uterus and also for the problems, for example, with the placenta preta. And during investigation, I say, okay, probably it's not possible to find a solution, yes, to reduce the cesarean in the world, because in real, yes, the cesarean increase in any part of the world, and obviously the problems with the maternal health. But what happens if we modify the consequence of the cesarean? You know that the origin of the placenta accreta spectrum is a defect in myometron. Yes, during a lot of time, the people think that the problem is the placenta that invaded, but the main problem is the problem in the defect in the uterus. And how can I do to reduce this? Yes, now it is made in a study, it is performed a study between France and Germany with 20,000 yes, prospective women to know if the cesarean in the upper part of the uterine segment is different than the lower one. And the preliminary result showed that is completely different. But what is the difference? You say, okay, I use the cut, yes, 3 centimeters. The big difference is the uterine blood supply of the uterine segment. Yes, in the normal area, yes, that is irrigated by terminal branches of the cervicovaginal artery, and it is also 30%, 30% of anastomosis in this lower part. But in the upper part of the uterus, you have 100% of anastomotic channels. And if you cut one, you have another one or another one. For this reason, yes, the healing is completely different. Yes, we try to start and study that is so difficult, especially to demonstrate it. Yes, we have, for example, samples of the many parts of the world about, for example, anatomic and geography of this part. But you know, we start a work here, yes, with a fresh course, but what happened? COVID appeared, and the study stopped, and I hope that we restart very soon. When you analyze, obviously, the consequence of the maternal death, if you look only this picture, you say, okay, it's quite impossible to solve. But if you pay attention, for example, the unsafe abortion and the hemorrhage, it's approximately 30% or more, 35% of the cost. And it's very high, yes. And during, for example, the 2 last decades, appear many simple, for example, procedure to apply over the uterus that is very cheap. Yes, Bakri balloon was designed at the first as a cheap balloon. But obviously, after the balloon is introduced in the industry, increase the value. But appear many alternatives now. But one of the best knowledge that appeared in 1995 is the compression suture. Compression suture, you can solve approximately 80% of postpartum hemorrhage for a uterine atony with one simple suture. But you need to acquire skill, and you need to retain the skill. You need to integrate, yes, to the praxia. The praxia is the movement that you remember in your brain that it is able to reproduce this, yes, in any moment. But obviously, this is a very old, for example, phrase, but obviously it is current problem now. The people need to change, and it's very difficult that the doctors and the people change. You know that only to introduce the pap smears need to 10 years, yes? And we talk about, for example, one of the big problem of maternal mortality, that is the cervical cancer. And you can prevent very well with a very simple study, but the doctors need 10 years to modify, yes, and to introduce this. And it is necessary to update our skills, update our knowledge, yes, to introduce a very good, simple technique to reduce this. When we try to analyze a big problem in every part of the world about maternal health, it is not, for example, a prenatal care, because it's so important, the family plan, the preconception, and not only the care during a hospital. Why? Because, for example, some ideas here in my country is to introduce more prenatal care, but less attention in the hospital. When you see this, for example, the World Health Organization tried to introduce very simple ideas, yes, with a big impact for the patient. And they try to attack these, for example, areas, for example, about the severe bleeding. You know that there is many investigation about the stable oxytocin. Yes, it's available now, stable oxytocin, because if you have oxytocin but not the cold chain, it is not an action. Yes, and the same happened, for example, with the problem with the iron. Yes, with the in the element in the food. Yes, the supplement in the food, and only 12% of eclampsia. That eclampsia, yes, rise, especially in developed countries, but unsafe abortion, severe bleeding, and, for example, iron supplement or treatment of malaria. In the whole, for example, scenario, there is a lot of action that all we can do it. Yes. Here in my country, the people in the special area, poor areas, try to go to the hospital to the people. Yes, and the cost of this was, yes, less than the problem, especially with the disease. But the thing is, you detect some problems, but obviously you need a support for the hospital. Yes, because it's always a chain. You need to have a good prenatal care, but also to solve the problem in the hospital. For this reason, and in conclusion, it is necessary a big effort for all of us to reduce maternal mortality, and it is very stimulating to see that the introduction of very simple measure result in very good effect to reduce maternal health. Yes, and all we need to work together, especially countries, governments, as a people, all as a team. Yes, and the entire scenario is so difficult to understand because it's only for the people, epidemiologists. Yes, and in our hospital, we try to attack, for example, some special areas. Probably for many people say, okay, but you only treat, for example, about obstetric hemorrhage. Yes, but if you put an effort on this in your hospital, it's very good. If you treat to introduce, for example, more iron, or for example, very good food, or detect malaria, is so good. The problem is very high, but the compromise is for all of us. Thank you so much.
Thank you so much, Professor Jose Miguel Palacios-Jaraquemada, MD, PhD, for the knowledge that has been given to us. Ladies and gentlemen, the next agenda is the speech by the Rector of Universitas Airlangga, represented by the Vice Rector of Universitas Airlangga for Internationalization, Digitalization, and Information. Dear Dr. Muhammad Miftahus Surur, MD, PhD, you may begin your speech.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Most cordial greetings from Universitas Airlangga Indonesia. The Honorable Dean of Faculty of Medicine, Universitas Airlangga, the Honorable Head of Department of Obstetric and Gynecology of Faculty of Medicine, Universitas Airlangga, and of course, our esteemed Adjunct Professor Candidate, Professor Jose Miguel Palacios-Jaraquemada, PhD from Department of Anatomy, Medical Faculty of Buenos Aires University, and the distinguished guests and all faculty members. I sincerely thank you for taking your time to be with us today. And on the inauguration of Professor Jose Miguel Palacios-Jaraquemada, PhD from Department of Anatomy, Medical Faculty of Buenos Aires University, as adjunct professor at the Faculty of Medicine, Universitas Airlangga. It is such an honor for me personally to be able to witness the milestones of a distinguished fellow academic. You see, in order to support the three pillars of education, it is crucial that every available human resource of the university can contribute, as well as exploring the limitless opportunities for the brighter future of education. And we pledge to always dedicate our achievements for the sole purpose of fulfilling these duties in upholding the three pillars of education. At the same time, these three pillars of education are the facilitator for the improvement of human resources itself. It's a cycle, a never-ending one, and the Universitas Airlangga aims to keep the wheel going. We are firmly aware that the pandemic has brought a significant shift as to how this cycle is being maintained. And with this new norm in the real of education experience, we are constantly regenerating various partnerships and collaborations, expanding our networking activities with overseas universities all over the world, and in doing so, providing necessary platforms and adequate environment for the improvement of human resources capabilities. And these are mainly why Universitas Airlangga regards our adjunct professor in high esteem. As our university's partner, adjunct professor play significant roles in our relentless endeavor to constantly strive for the university's overall relentless academic performance enhancement. Proposed academic collaborations, not to mention the potential collaborative research, are the very strands woven into the elaborate cobwebs of our expanding network. Hence, we are forever grateful for the adjunct professor unwavering support that our university is able to maintain our steadily rising global reputations. On behalf of academic from Universitas Airlangga, we would like to once again thanks and congratulate to Professor Jose Miguel Palacios-Jaraquemada for his remarkable achievement. And I know that I can rely of Professor Jose Miguel Palacios-Jaraquemada to be able to play his part in upholding the three pillars of education. Having acknowledged all of aforementioned, it is unfortunate indeed that I cannot be with you all in person to celebrate today's milestones as we normally would have. However, please know that my thoughts and warm wishes will always be with you, and I'm holding on to hope that we will eventually be able to see each other face to face by next year. Here's to a new beginning and more windows of opportunities for Professor Jose Miguel Palacios-Jaraquemada. May blessings be with all upon you always. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Muhammad Miftahul Surur, MD, PhD. Ladies and gentlemen, now we reach the main event of today's agenda, the inauguration ceremony, honorarily referring as the adjunct professor to Professor Jose Miguel Palacios-Jaraquemada, MD, PhD. We invite the representative of the Rector of Universitas Airlangga, our Vice Rector of Universitas Airlangga for Internationalization, Digitalization and Information, Dr. Muhammad Miftahul Surur, MD, PhD, to grant the award of honor to Professor Jose Miguel Palacios-Jaraquemada, MD, PhD. To our Vice Rector of Universitas Airlangga, please hand symbolically the certificate of honor to Professor Jose Miguel Palacios-Jaraquemada, MD, PhD, as the adjunct professor of Universitas Airlangga.
Thank you very much to Professor Jose Miguel Palacios-Jaraquemada, PhD. On behalf of Universitas Airlangga and in particular the Faculty of Medicine, Universitas Airlangga, I hand the certificates and plaque as your acknowledgement as the adjunct professor of obstetric and gynecology department of Faculty of Medicine, Universitas Airlangga. Congratulations.
Thank you so much. Thank you.
Thank you, Dr. Muhammad Miftahul Surur, MD, PhD. Thank you and congratulations to Professor Jose Miguel Palacios-Jaraquemada, MD, PhD. Ladies and gentlemen, that was the end of inauguration ceremony. Dear Vice Rector, Dean, Vice Dean, and distinguished guests may leave the Zoom meeting. And ladies and gentlemen, the next agenda is expert lecture by Professor Jose Miguel Palacios-Jaraquemada entitled History and Evolution Techniques of Abnormally Invasive Placenta. There will be Dr. Aditya Warman, MD, PhD, as the moderator. Dr. Aditya Warman is also the head of Placenta Accreta Task Force in Indonesia. There also will be Professor Eri Gumila Dahlan, MD, PhD, as the panelist. Professor Eri is also the chairman of Indonesia Veterinary Medicine Association.
Thank you so
Dear
much. Yes.
Dear Dr. Aditya Warman, MD, PhD, the time is yours.
Okay, I tried to explain briefly the history evolution techniques of anomaly invasive placenta. Yes, this is a person who performed the first description. This is a special doctor that practiced medicine in Basilea, Suiza, and there is currently a hospital with the name of Felix Platter. This is the first macroscopic description of this. The second one was for this midwife. This midwife is originally from Berlin. Is also writer. Yes, is Justine. Wrote many books about obstetrics. Yes, and describe, for example, a case of a very detailed case in which she moved pieces of the placenta until the woman died. This is a doctor from Edinburgh that described microscopically the first description of the placenta preta. This is a doctor named Very Hart. Yes, many people think that the first description, yes, is for Hertrick. Yes, but Hertrick work is the first, for example, group of the people that operated placenta preta. And this is very interesting because there is a moment that the people change the term of adherent placenta turns to placenta preta. And the first person who talked about the placenta preta was the Professor Wolbach, yes, in University of Tübingen. University of Tübingen in the south of Germany, yes, included many people that study at the same time the placenta preta. Yes, obviously the Dr. Weich performed many cases, but if you pay attention, yes, after the first person who talked about this was the Professor Wolbach. Some months ago, I tried to get this publication. Was very interesting because it is quite impossible to establish a communication with the University of Tübingen because it's only for institution. I talked with a friend in Germany. He asked for a copy, yes, of this article. Now I try to translate, yes, but it's very detailed description of the placenta preta. It's in Germany. But the thing is, what is the moment that the cesarean arrives? Yes, I talk about in 1950, the percentage of cesarean was very low in the state, and in 1950, yes, the quantity of cases of placenta preta are less than 10 published. But what happened in the moment that the people change for the corporal cesarean to segmental cesarean? Yes, and appeared the name of Dr. Ferdinand Ketter. And the people say, who is Dr. Ferdinand Ketter? This was a very well-known doctor that performed the first modern cesarean section. Yes, a transverse or segmental cesarean section. But all the people told me, but I hear that was Dr. Munroker. Yes, I tried to explain what is the mistake. This is not the person really that performed the first transverse cesarean. Some not well-known doctors, yes, in Germany, perform a segmental cesarean. But Ferdinand Kerr was a professor, yes, and a person who knows perfectly to manage this new knowledge. Yes, but what happened was he was the first person that performed and published. But what happened, for example, with this doctor? This doctor, for example, was in similar ages, introduced the practice of suture. You say, okay, what happened with the suture? Before this person, when you practice a corporal cesarean, nobody introduced, for example, sutures, because the problem with the sutures is infection and was very complicated. You left, for example, the uterus without any suture, and then obviously the patient died. And appear, for example, another person, very well known, Dr. Marion Sims in the United States, that worked together. But this is Dr. John Martin Munro-Kerr. The ability of Professor Munro-Kerr was rediscover and spread the knowledge of the segmental cesarean. Yes, and was a person that presented in the American Society of Obstetrics and Gynecology to talk about the advantages of the segmental cesarean. You know that there is practically minimal bleeding. The use of suture are very good, but in the original paper of Professor Munro-Kerr in 1926, there is a small paragraph that says that the only potential problem of this lower cesarean is the high percentage of collagen in this area that probably, yes, produce a fibrotic scar. Yes, and in the original paper, Dr. Munro-Kerr said this problem. And what happened is a high quantity of collagen and low irrigation, low blood supply. For this reason, in some areas of the uterine segment, the healing is not so good. When the healing is not so good, when the embryo attached in this area, there is some problem with the develop of the decidua. Yes, and the reaction between the two tissues produce an apparent placental invasion. Why? Because the placenta goes through the problem of the muscle. And the people say, okay, this is true or not? Many people study about if the problem is the uterus of the placenta, but if the primary problem, yes, it is the placenta, yes, you have many placenta secretas in many parts of the uterus, and is only practically produced in the anterior wall in the lower segment. Yes, when I study in Europe, the type of collagen, yes, there is a lot of collagen, approximately 12, but appear and is very special collagen after the placenta is attached that is named collagen 5. And when you produce an abnormal healing, the quantity of collagen 5 is very high. There is no demonstration that the collagen 5, yes, is the real origin of the attachment of the placenta, but it's a special collagen that they only develop in cases of abnormal, for example, healing in areas with a lot of collagen. And this is a problem in the real life. When you solve one problem, appear a new one. Yes, and in this case, you solve the problem of the cesarean, but appear a new one that is invasion of the placenta. Obviously, the consequence of the change of the place of the cesarean was remarkable. Why? Because you decrease, yes, the possibility of uterine rupture in 10% to a half percent, 1%. Yes, it's dramatically. And at that moment, Professor Muruker said that obviously it's not possible to attempt a vaginal birth for this problem. Yes, and many years ago, yes, the people studied the possibility to predict complication when you try to perform a vaginal delivery after cesarean. And the problem is not the uterine thickness, because in some cases you have 1 centimeter or, for example, a half centimeter. The problem is the elasticity of the tissues. You have, for example, a fibrous scar that probably produces some rupture, yes, suddenly, yes, with 1 centimeter. And the cesarean is go up in every part of the world. Yes, near of our country, in Brazil, for example, in this data is 55%, but approximately now in the private practice is about 70 to 90%, because especially mothers ask for cesarean. And in general, yes, in the second cesarean ask for tubal ligation. Yet, but it's very, very common. The same happened, for example, in Egypt. The same happened, for example, in Mexico, and obviously in some areas of your country. Yes, the same happened in the many countries in the world. We have, for example, in Central America, a similar situation. But the problem is that Rosie have one health. Yes, and sometimes receive a lot of patients in 1 week. Rosie is very skillful, but the cost of this pathology or this disease is very high. Not only for the people, it's very complicated to acquire skill, but also for the institution, because you consume a lot of resources. It is not simple to have a lot of blood and a lot of resources in one hospital. When we think in the past, what is the mortality when you, for example, at the beginning of the 20th century, the progress when you move the placenta is about 70% of mortality. And it's a big problem. The big problem is the blood loss. And until 1933 is the same year that the Golden Gate Bridge started the construction and the Hitler Rise is the same area. This is the first report in the world with the treatment, yes, of left to the placenta in situ. Why? Because the people know if you try to remove the placenta, yes, practically 70% of the patients die. And this doctor think, okay, what happened if I left the placenta? The problem obviously is infection, yes, but in this case, and after 60 days, the patient alive. Was the first case for Prof. Dr. Capecci, yes, in Italy, and he said that this digestione of the placenta reabsorption. The thing is, this very old surgery is safest that to perform hysterectomy. Why? Because hysterectomy is a lot of complication. But what happened during the time? Yes, this is a Massachusetts General Hospital old building, and immediately beside of this picture there is a dome, and this is dome is historical dome because was performed the first anesthesia in the world. On the right, this is Professor Warren. Professor Warren was the head of the surgery, incredible hard person, And Morton was a dentist and introduced the anesthesia, but with the idea to ask for some money. Yes. At the beginning, he tried to cover the structure of the ether and obviously to sell this new product to the people. You imagine at that moment you suffer in all the surgery and you produce infection in all the surgery. And this very hard doctor for the first time cry in front of all the people and say, this is a point that modify the history of the surgery. One is the anesthesia. Yes, but the another problem was infection. You know, in the case of the placenta in situ, the patient has had an infection for 60 days, and finally, obviously, recovery. But what happened with Dr. Semmelweis that start with the concept to clean your hands, and then with the theory of Louis Pasteur about the germs. Yes, but Louis Pasteur was not a doctor. Yes, but this knowledge, yes, and of the figure of Joseph Lister that starts with the antisepsis. Yes, he introduced in a solution of phenic acid. Yes, this is here, for example, and then to use this device to reduce, for example, infection. And the Lister method was very, very obsessive to do this and follow for many persons, and then you manage the anesthesia, and then you manage the infection. And the first successful case of obstetric hysterectomy was performed in 1876. Yes, this is a first reference. It's about a lot of discovery in medicine at the end of 19th or the beginning of the 20th century. What happened with the other problem? The other problem, first anesthesia, second infection, and third, the blood loss. And appeared the name of Dr. Kelly. Dr. Kelly had performed a special type of surgery that included elongation of the internal iliac artery for first time. That is not really first time. The first time that it was used, for example, was used in 1812 in Mexico for the Dr. Stephen of Veracruz, yes, in the case of gluteal aneurysm. But it's not published properly, yes, and the person who appears with the first was this. And this is a special case of Dr. Kelly. He's a very young woman, he's 35 years old, with a cervical cancer and with bleeding, but no extension of the cervical cancer a lot. And obviously, a continuous bleeding is a high morbidity. And nobody knows what happened. What is the solution? And Dr. Kelly, yes, performed a ligature of the both iliac internal artery, and the paper was published as a name of the best procedure to control bleeding into the pelvis. But what happened then? This is a special case. Why? Because the most anastomotic components into the pelvis are infiltrated by the tumor. And 50 years after that, the obstetrician start to use this procedure. But the people say, okay, it's not so good. So Dr. Kelly said, but what happened? Why some procedures are good and others not? There is some problem, obviously. And At the beginning of the 20th century appears, yes, an Argentinian physician that is named Luis Agote that start with the citrate into the blood to be available to the transfusion for all the people. Yes, this is another advance in the history of this disease. Because you imagine, if you have a problem with the patient, we have not anesthesia, problem with infection, the vascular control, and the blood loss. And there is a fourth problem. There is not, for example, the specialty of intensive care. And in 1958, start for the first time in the world, yes, the unit of intensive care. Yes, this is the first time that intensive care doctor establishes a specialty. Yes, and all of these are interconnected with the treatment of placenta preta. Why? Because you need a lot of factors to do a good surgery. And a lot of problems happen during many years because some people say, okay, it's a good procedure, and another is not. Until appear a Dr. Robert Clay Barchel. This is a unique picture of the Dr. Barchel. Yes, there is practically not a picture, and start many studies from 1966 until 69. He tried to demonstrate what really happened when you perform a ligature of iliac internal artery. And the conclusions are very, very clear for the people, because when you ligated the internal iliac artery, you change the arterial system, yes, in the venous system. Why? Because after ligature, you have a 50% of the blood flow. Okay, what happened? I performed a ligature, and during these years, Dr. Burchell introduced some catheters to measure, for example, the arterial pressure, and the conclusion was, first, you change only 50% of the blood flow. You reduce, yes, the pressure in 70%. And for the unique and the middle organ as a uterus, a minimum procedure is a ligature, bilateral ligature. Why? Because most anastomotic systems into the pelvic are vertical, not horizontal. Yes? And after this study, 4 years study of Dr. Barchel, another specialty that used a lot is traumatologists, yes, abandoned this technique for a while. Yes, but not the obstetrician. Obstetrician restarts again, yes, and in 1979, Dr. Houston, yes, introduced the embolization, the first case of embolization in a persistent massive obstetric hemorrhage after a ligature of the internal iliac artery. Dr. Houston was a genius because to enter into the pelvis when you ligated the internal iliac artery, you need to introduce in femoral, yes, a collateral, internal collateral of in the upper part of the thigh, and then to introduce the catheter to the pelvis. It's a very, very complicated procedure. And what happened with Dr. Ravina? Dr. Ravina was French, yes, and is beside of the old nice woman. And Dr. Ravina was the first person that treated a case of hemorrhage for myomas. And a friend asked for some procedure to avoid hysterectomy in this lady. And Dr. Ravina said, okay, we introduce some material inside, and probably after a few days, we need to remove the uterus. But what happened? Nothing. There is no consequence of the, for example, uterine necrosis, and reduce the size of the myomas. And then after 5 years, yes, Dr. Ravina started with the first work. Until this moment, yes, the people think that when you occluded the uterine artery, the uterus replaced the blood flow for the upper pedicle. The upper pedicle is mainly the ovary artery and the round ligament artery. Yes. For example, Dr. Worthington Kish wrote a paper named State of the Art of Uterine Artery Embolization, and say that when you occlude it, the uterine artery replace the blood flow for the upper pedicle. But again, start the preliminary works with the idea to uterine transplant. And what happened? These people published in the Human Reproduction that when you perform, yes, a compression of the isthmus, yes, apparently only both uterine arteries, the upper pedicle is not able to maintain the vitality of the uterus after 6 hours. The uterus starts necrosis. And the thing is, it is not the upper pedicle, what is the replacement of the blood flow? Nobody knows. And with this idea, I start anatomical and radiologist study to know what happened if you occluded the both uterine artery. And for example, appear, yes, a new system in the lower part of the uterus. This is a corpse, yes. This is a promontorium. This is a common iliac artery. This is an ovary, uterus. This is a vagina, cul-de-sac, yes, and this is a bladder. This is a ovary artery and uterine artery. That is all the people we learn about this. 2 pedicles. But what happened with all these pedicles? These pedicles are developed below the peritoneal reflection and arise from the internal iliac artery node, from the posterior branch, yes, from the pudendal internal artery. And this is a big difference. Why? Because if you perform, for example, embolization of the uterine artery, only you can stop the bleeding in the uterine body, but not in the lower part. The lower part, what happened? Is a placenta creta. For this reason, when the embolization starts, yes, apparently a new knowledge, that is not so efficient that the people think. Why? Because you control only part of the pedicles, but not the lower part. Yes, and at that moment, in 2006, we changed the theory about the replacement of the blood flow. And this knowledge was proved by angiography, in which the people put a catheter in the pudendal internal artery until the vaginal artery, and then when the people push, for example, a contrast material, you can see all the uterine irrigation without touching the uterine artery. For this reason, if you occluded both pedicle, remember, when the people start to compress the uterine segment, compress 2 pedicles, the uterine artery, but also the vessel that coming from the vagina to the uterus. We need 8 years of investigation to understand what is this system work. Yes, and then we apply this knowledge to create a new technique, and then we need 30 years of surgical research to publish, yes, an experience about 400 cases of many types of placenta acreta spectrum, in which if you manage these pellicles without embolization, only with a specific ligature, you can preserve approximately 80% of the uterus. Obviously, the people say, okay, this is the goal. Now, the people say, okay, you left the uterus, but the uterus is useless. And then, during this period, remember that say that in Argentina, we have a high, for example, percentage of the Jewish people that want to become pregnant again, again, and again. And after we collected 200 of cases of pregnancy after repair, we know that the procedures are very good for the people and to perform reconstruction in anterior wall. Why? Because we remove all this tissue and perform the suture as the first cesarean with healthy tissues. Now, we have many people in the world, for example, one is Rosie, but it's not only for Rosie, is from Indonesia. Rosie is a very stimulated person, completely involved in the problem, and as a single person, find me and try to incorporate solutions for your country. It is a very smart person. It is not any problem to consult for problems. We exchange information, yes, during a week or studies. And the same happened with Dr. Álvaro José Nieto Calveche from Colombia, that we also collaborated, yes, in many cases, and putting special attention and in the problems of blood loss. Why? Because it remains in the mind of the people that the ligature of iliac internal artery is a good procedure for all the pelvic bleeding. But now there is approximately 8 papers, prospective papers that demonstrated that is not a good procedure to control pelvic bleeding. Only control pelvic bleeding in upper part or of peritoneal reflection, not from below. And this is a new blood to continuous development. And for this reason, these people stimulate a lot. I'm very happy to collaborate with Dr. Rossi, Dr. Alvaro, or many people that are very stimulated to continue. Why? Because all this time, yes, for investigation is to pass to another person, not to keep me. It's useless. I need to pass, and these people try to modify. In the case of Rossi, for example, reduce a lot the cases of blood loss. Yes, Dr. Alvaro also used, for example, the aorta in the vascular control. Why? Because when you control the aorta, you control especially the 3 components, the iliac internal, iliac external, and femoral component. All of these are interconnected. And if you use in one simple area, a balloon or your hand or compression, you can control all pelvic bleeding. Obviously, it's not a big solution. It's only for a while. Why? Because it's a primary vascular control in this area. Rossi used a lot, for example, a vascular control in aorta. You can use a catheter, you can use your hand, a loop. Yes, it is all are the same. But in a recent time, for example, Dr. Alvaro try to know what is the person that really needs to use aortic vascular control or not. This is a new knowledge, because all the people say that is good or not, or if you spend money or not. But it is really important to know the indication. In summary, you need to have a lot of skills resource, knowledge, training. You need to work with the team, vascular control, yes, to solve one simple case of placental accreta. This is a challenging. Why? Because it is better to have one simple center in which you receive the patient, yes, like in Surabaya, because you increase your experience, and it's useless, completely useless, if you treat one or two patients, for example, every 6 months. Yes, the learning curve obviously is less. The possibility to create a group obviously is very difficult. In summary, placenta accreta is still a problem of maternal mortality. Yes, and obviously the possibility to reduce a cesarean rate is probably is not possible. For this reason, another way is to find another solution to reduce the damage, and it is necessary a collaborative work in this point. For example, Dr. Alvaro starts a telehealth. What is telehealth? You know that telemedicine is so complicated, is plenty of legal problem, you need a lot of resource, but for a telehealth, you need only, yes, a cell phone. And with a simple cell phone, you can introduce knowledge to the other person. He published recently, and it's very comfortable to know that it's a goal for Dr. Alvaro, because modify the possibility to reduce the maternal mortality in many hospitals with a low resource. For this reason, experience is very good if you share or if you introduce new possibilities for the people. Thank you so much.
Thank you. Thank you, Professor Usi, for the
Thank you. Thank you, Professor Husi, for interesting lecture. Indonesia has a high incidence of the placenta accreta because now cessation rate in Indonesia is rise, and this is a problem in our country, our hospital, and with your support by Adjunct professor here, we hope that we have to solve this problem. For the first, I want to introduce that I'm moderator in this session. My name is Aditya. I'm also the head of the task force of Indonesian placenta accreta. And in my left side is Professor Eri Gumilar. Professor Eri is the head of the Feto-Maternal Society, Indonesian Feto-Maternal Society also. He is a panelist in this session. May I introduce too that this lecture is followed by member of Indonesian Placenta Accreta. It's approximately 32 members that follow and pass your course in Indonesian 2 years ago in Surabaya. They all followed this lecture, and also 300 of obstetrician in Indonesia. Thank you, Professor Jose. And may I let Professor Eri to start the discussion as the panelist. Time is yours, Professor Eri.
Bismillahirrahmanirrahim.
How are you,
Hello.
Doctor?
Prof. Jose, good night. But I still believe that you still have good endurance, even just now approaching to a sleeping time, right? So just local time over there, it should be 11 p.m.
It's about 11, yes.
Yes, okay. Really, just needless to say, just your speech from earlier and then no presentations. It's very fantastic. We know well, just according to the last paper, where the theorem of possible cause of placenta preta is the defect located between myometrial, and then the failure of this communicate myometrial, the endometrial just entering so deep, and then that is the happening worse and worse. So would you please just, you are extending, traveling to many countries over the world, right? China, Malaysia, and of course, Latin America. Like 2 weeks ago, we had even communicate over to Colombia, Bogota. So can we say that we just only blaming a previous cesarean, right? For instance, that the incision just look to be lower, or just by your explanations over the screen,
Yes.
it could be another material in fulvia, just like the thread and the suture, or just again you are stressing lecture to the effort to reduce maternal mortality include your infection. So just we are in Indonesia, we are tropical and coastal countries, right? Infection so close and familiar. So my point in this question is it the only possible cause is previous cesareans, or just maybe nutrition?
Okay, yes.
Yeah.
Yes, I understand. Many people study this, and for example, you know that also the possibility to use 1 layer or second or 2 layers. Yes. Recently, 2 authors. One I know is in German. This is a very obsessive person, and I remember that in your house he told me, I will demonstrate it that 1 layer or 2 layers be different. And start a project with another obsessive person, and after 200 patients, the conclusion was there is not any difference. And when you analyze all the details that the investigation take in account about the place of the cesarean, no one is the target to the blood supply of the uterus. And the collect information was very hard for me, because there is some very good thesis, doctorate thesis. One is in Poland and another is in the United States that I finally found in my hands and demonstrated this knowledge that is different, the upper irrigation of the uterine segment and the lower one. But recently, in the first part of the collaborative work between France and Germany, yes, in about 300 of patients, yes, they want to collect 20,000. The difference are very high. For example, the possibility of a big defect in when you perform a cesarean in the lower part of the uterine segment is about 70%. In the contrast, in the upper part, it's about 50%. It's a big difference, but these people need to be in account one special detail. It was very difficult.
Excuse me. So just by the way, sorry, just I interrupt a little bit your explanation. It's a very good one. But we are in obstetric. We know that the cesarean technique, right,
yes,
is from a very classic one, by making bladder flap, right, and then to make decisions where's the locate of incisions. So just it look a bit lower. Can we say that it's the
I know.
cost?
I know. The people, for example, there is another investigation in Italy that study what is the advantage or disadvantage to create a vesical flap. And the conclusion is you never need to create a flap. One reason, yes, it is not necessary and maybe produce some hematomas, but another reason is that you cut some microscopic blood supply between the uterus and the bladder. And I think that in the following years, maybe we have a very good information to make decisions. And probably the decision was available for all the people and for all the obstetricians, because you need to know only one detail. What is the way to distinguish what is the limit of the uterine segment? And by inside, it is very clear because histology is completely different. But what happened in the external way? And it was demonstrated that the limit of the uterine segment is a place in which the peritoneum is adherent with the uterus. Yes, you have approximately 4-5 centimeters to the fold. Yes,
it is typically classic low segment cesarean.
Yes.
That's why.
Yes.
What is inherent from the higher our teacher in the old time until the latest generations, that we recommend by bladder flap and then make a lower incision. And then Prof. Jose, we find now after developing so far the cases of the placenta preta, even coming from no previous cesareans. That's amazing us. It's amazing one. Since after collecting 100 cases from Rossi, yes, just a few cases just arose from this collecting that they don't have any previous cesareans. So just I'm attracted to your paper now, just involving at the level of molecular biology is the fibroblast, that you are one-step surgery, right, by excision.
Yes.
That is destination is not other than to make the better quality of cesarean. Isn't it? Oh, what was your comment here? So just the fibroblast.
Yes. I think that now is so early to have a good conclusions. Yes, but the stimulating thing is that many people are focusing in all of details that you comment, and many of these to find the solution. I hope that in the following years we reach to a very good result for this. But until this moment, we only have ideas and we have only preliminary studies, no more. The other things is only suppositions, yes, theories, yes. But I agree with you that many factors probably are interconnected. Yes, it's not so simple that the people thought.
Thank you, Professor Jose. One of the member organizing committee signed about the time, but I offer Professor Eri one last question.
Okay.
Yeah,
Okay.
one last question because the organizing committee is signed about the time.
Thank you, Dr. Adja. Prof. Jose, now this morning, the reality, we will have you, right? So happy we are, right? That really just be excited by your stunning experience, hundreds of publications as the book author, publication author. Then from our side, we had already been appointed where your compulsory duty at the adjunct professor is number one, teach us to scientific writing, leading to a world reputable journal. That's really very important. And giving a medical student, the young generations lecture, and as well as, of course, as the for the PhD program, we may have already have some nominee of the candidate. So my question is that I need your estimate. I need your estimations. We know that we admire your professorate. So would you please just give us estimate that we will stepping forward our university, right? That may I know that what is our future? It's a simple question.
Yes, I think that the first idea is to know, for example, some special knowledge about the management and to create, for example, an ABC, what to do and do not. Yes, many people, for example, talk, one example, a continuous talking about the methotrexate in the case of placenta creta. But many years ago, the head of the FIGO talked about it was my mistake because I was consulted about a case of placenta creta that is extensive in all areas of the pelvis, and I thought about the possibility to use methotrexate. But later, a pathologist told me that the percentage of mitosis is less than 1%. And there is also cases of injection of methotrexate by the cord, but there is some death, immediately death for this procedure. Recently, for example, I read about the use of concentrated of hypophysis to reduce, for example, vasopressin, to reduce in some areas the bleeding. But there is a publication about the immediate death when you inject it, yes, unintentionally in the leg into the uterus. And I think that if the obstetrician manage the clinical aspect, the early clinical aspect of the postpartum hemorrhage, it is good. Second, the ability to replace the volume, yes, and start protocol. Why? Because the most important problem is in the detection and the initial treatment. In general, the treatment is late, and in general is a little treatment, not real one. And if you wait, in this case, for the anesthetician, obviously you lost the patient. Why? Because the bleeding in the case of postpartum hemorrhage is very high. But you know that the blood, the blood flow in the uterus at term is about 500 to 800. But you think in the 500 and you think in the 10%, 50 milliliters by minute. The time to move the patient until receive the treatment, for example, the surgery, is about 1 hour. In 1 hour, with the 10%, the blood loss is 3 liters. For this reason, it's so important that the unit note about these details to manage these cases, not so late, because the big problem or the high quantity of mortality is a problem associated with acidosis, coagulopathy, and all continuous bleeding end in coagulopathy. And you know the problem of the coagulopathy. And it's so important to introduce the concept of the primary vascular control and the secondary vascular control. In the first case, you only stop the bleeding. It's to avoid that the patient enter in hemorrhagic shock enter in coagulopathy and modify the acid-base state. Is a solution? Not at all. You only prevent for heavy complication. And then with time, because if you compress, for example, the abdominal aorta, the time that you have for reaction is 1 hour. And then to treat, yes, the specific problem. But what is the, for example, the general knowledge when you stay in the residence, for example, here, you need to remove the uterus as soon as possible. But the people, for example, know that the blood inside the uterus is about 2 liters. You imagine if you have the patient in shock and you remove 2 liters.
Okay.
It's very important that the obstetrician manage this concept.
Thank you so much, Professor Jose. And even though the reality, the dream come true, but it is only the starting point for us. I really forward it to the moderator. Okay.
Thank you. Thank you for the great discussion from both of you, Professor. This discussion is useful for our knowledge to improve our services in placenta accreta. But because of the very limited time, as we know in Argentina now is quite midnight, we have to stop our discussion and our session. And organizing committee has asked me to summarize from your oration and also this lecture. The first one is to remind all the obstetrician especially that all the uterine surgery, especially cesarean section, has consequences in the next pregnancy. For example, is placenta accreta. And the second is improving medical doctor and hospital to manage placenta accreta. Include in this here is how to screen in the mesh area. The third is to build a joint and collaborative course and research, both national and international, for placenta accreta. This is all of my resume for our discussion. And again, thank you for the great lecture and discussion. And on behalf of Airlangga University, Faculty of Medicine, officially I close this session. Thank you, Professor Eri. Thank you, Professor Jose. Gracias. Sue buven descanso.
Okay. Thank you so much. Thank you so much. It's a pleasure to be with you.
Thank you.
Thank you. Thank you. Thank you so much.
Bye, Professor.
Thank you.
Thank you so much, Professor Jose Miguel Palacios-Jaraquemada, MD, PhD, for the knowledge that has been given to us. And thank you so much, Dr. Aditya Warman, MD, PhD. And also thank you, Professor Dr. Eri Gumilar Dahlan, MD, PhD. Applause again for us. Okay, ladies and gentlemen, that is our last agenda for this special event. May that we have conducted today will have benefits and advantages to all of us. Thank you so much for your attention. Thank you very much. I hope we are staying safe and healthy. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Cek. Cek.
Yes, all of distinguished guests, please come to take some picture together in the front of aula.